This abstract essentially, in patients who are newly diagnosed with multiple myeloma, clinical guidelines commonly recommend that they receive induction chemotherapy followed by high-dose melphalan and autologous transplant. However, in patients who are older or more frail, transplant may not be a treatment option. So essentially, in the National Comprehensive Care Network guidelines, or NCCN guidelines, the two preferred treatment option for this patient population are Daratumumab, Lenalidomide, Dexamethasone, or DRd, and Bortezomib, Lenalidomide, Dexamethasone, or VRd. So the goal of our study was really to compare the time to next treatment or death between transplant-ineligible patients with newly diagnosed myeloma, but also to look at or to possibly add to the existing evidence base regarding comparative effectiveness among these two regimens. The database that we used for this study was the Centris database. It was a retrospective analysis. And also, in terms of methodology or statistical methodology, we used the inverse probability of treatment weighting to essentially adjust baseline characteristics between the two groups. In terms of results or eligible patients, there were 643 eligible patients, 149 received DRd, and 494 received VRd. In terms of results, we identified that frontline DRd was associated with a longer time to next treatment or death compared to the VRd arm. We identified that DRd was associated with a 42% lower risk of advancing to another therapy or dying, as evidenced by an adjusted hazard ratio of 0.58. Additionally, the median time to next treatment for DRd was approximately 38 months compared to 19 months for the VRd cohort. So essentially, the study does have limitations, as all other retrospective analyses do, to include administrative bias or missing some, ECOG performance status or high-risk cytogenetics, which could contextualize our findings. And I think it's important to point out that time to next treatment is not equivalent to progression-free survival. It is not a direct proxy for progression-free survival because there are factors that can impact time to next treatment, physician and or patient-related factors that may lead to treatment discontinuation before a true progression by IMWG response criteria. And time to next treatment can't underestimate progression-free survival. So in conclusion, our study does demonstrate superiority of DRd over VRd in terms of time to next treatment or death, as evidenced by that 42% risk reduction. And it does add to the existing evidence or breadth of knowledge, as shown in other studies like Taurus or Pegasus and other adjusted indirect comparisons. But hopefully, in the absence of randomized head-to-head control clinical trials, our study does show the superior efficacy of DRd and hopefully assist clinicians in informed decision-making when treating patients with newly diagnosed myeloma who may be transplant ineligible. Thank you.